Hello. Good morning, everybody. Can you hear me okay? All right. I'm excited to share with you some of the work that we've been doing at Texas Children's Hospital, Baylor College of Medicine. And you can see it took so many of us at Texas Children's. And just like our team, Texas Children's is also bigger. Kind of like in Texas, everything is bigger. We see over 3,000 patients in a given year with type 1 diabetes. With type 2 diabetes, it's close to 800. Uh, Out of this, in the last year at least, over 16 years old, we had about 1,000 patients that were seen. And then for type 2, it was close to 500 patients, 40% of them publicly insured. And you can see we have a large group of providers ranging from endocrinologists to nurse practitioners, PAs, diabetes educators, social work, and so forth. What I want to point out is that within the state of Texas, in Houston alone, we have 4 major hospitals, and one is in Austin, and then 6 satellite clinics. And the reason why I share that that data with you is because to kind of collaborate and coordinate such QI work is massive within, such a large institution. And the work that we do cannot be done just by one person alone. It really takes a village. So some of the background that I won't go so much into detail because Dr. Mary covered it very well and set the stage. But adolescent period and transitioning from PD to adult care, as we all know, is such a delicate and vulnerable period where not only are they going through so many developmental physiological changes, but mentally, my goodness, PSATs, SATs, the pressure of applying for colleges, and just the peer pressure alone is so much for them to absorb. If that transition is poorly coordinated, we know that it leads to such a significant gap in care, and including decreased follow-ups, worsening glycemic control, as Dr. Mary pointed out. Not to mention this chart on the right is nicely illustrated by Dr. Sarah Carruthers and her colleagues who have done such an amazing job in the transitions world. But what that graph sort of highlights is that the time from the last PD endo appointment to the first adult endocrine appointment, if there is such a delay in that or a gap, then the A1C levels will continue to decline. As such, the ADA and the ISPAD guidelines really emphasize a planned transition process where we need a structured education and preparation to sort of have a therapeutic end from a PD to an adult relationship with the patient. So a year and a half ago, which is the duration of this project really, is we surveyed providers, about 31 providers. And what we wanted to first find out was what is the age of first discussion of the transition. And we can see that it was a little bit on the later end, which is close to 17 years of age. And a vast majority of the providers, yes, they felt comfortable doing the transition discussion, but what they were not comfortable with here, you see, is the discussions on alcohol, pregnancy, and expectations. So sex, drugs, rock and roll, sensitive topics. The key driver diagram here, the fishbone diagram here really kind of points towards the key drivers as to what's obstructing the transition planning at our institution, where we didn't have any formalized transition process or policies in place. The providers were not comfortable discussing those topics. As I mentioned, patients were sort of lost in the system, and that has been also validated through some of the focus group surveys and focus group discussions that were held with adult endo providers through our psychology group, along with our patients. And there was not a standardized way to document the education that we provide, and we didn't have any education materials to begin with. So a lot of work needed to be done. So we had this ambitious goal of developing a transitions roadmap and increasing the rate of older adolescents age 16 and up with a documented transition plan by 30% over a year and a half from a baseline of 20%. You can see a year and a half, right? So 2023 to June of 2025. And we employed a series of PDSA cycles to kind of make this work happen. the first thing that we did was in 2023, November, we implemented a transitions policy with a transition curriculum. So you can see that on the right side, where the providers, the diabetes educators, the social workers, everybody sort of had a delineated task list as to what they were supposed to do, along with the time period. So starting at the age of 16 is when we initiate that transition discussion. So by the time our patients are 17, 18, 19, it's not such a rude awakening and such a surprise for them. On the bottom that you see is our provider doc flow sheet. That is what it's called in our Epic EMR. And we leverage this technology to sort of have a documented date of transfer, along with those key 4 sensitive topics that were identified. And so one of the other things that we needed to do is to have a very clear roadmap, whether it was a provider, endocrinology a specialist that's discussing the transition, or a diabetes educator. We needed to ensure that everybody was sort of on the same page and providing the same type of education. So on the bottom, you see a flowchart transition. So at the age of 15, 16 is when we start discussing driving education. And then 16, 17 is more of discussing pregnancy and alcohol and diabetes. And then once they are 17 to 18 years of age is when we are bringing up the insurance education discussion. So you can see this was a very streamlined, very structured education that we developed. Along with this, we held a transition seminar for over 100 of our staff and providers across the Houston area to increase their confidence and comfort in managing transitions. And then we also provided them with a list of adult endocrinology providers across the Houston area. And then on the bottom, you can see is our education materials, along with having that embedded into the clinic passport. So sorry, I think I just went backwards for some reason. Okay, there we go. So you can see the results were not surprising. With the fruit of our labor that we had is that we achieved our SMART aim from increasing the documented transition plan from a baseline of 20 to 50% for the same cohort of patients that I mentioned in my initial slides. And this was a significantly statistical centerline shift from a baseline of 49 to 65% by the summer of this year. And many, many thanks to Don Buckingham, who is in our audience today, for really giving us this graph and sort of highlighting the work that we are doing in a very visual format. And in summary, the lessons that we learned along the way is the team-based care was really a roadmap to a successful transition. And we had to leverage our EMR integration, a multidisciplinary approach to transitions, and having a very clear distribution for the team members. In future, we do hope to sustain these improvements and sort of monitor patients' outcomes like post-transition, what Dr. Nana was referring to earlier, like what is that percentage of patients that actually do have that adult endocrinology appointment secured. And then if there's any barriers for publicly health insureds, and that's something that we want to look at as well. And I cannot do this alone. It takes a village, and I'm very grateful for the Texas Children's Diabetes and Endocrine Service. Dr. Sonabin, who's our division chief, and giving us the infrastructure and really the support from the leadership and for us to be able to do the work that we can. We have 5 different diabetes quality improvement team, and you can see the list of folks that are mentioned in the names. They all take part in leading these initiatives in one way or another. Mark Rittenhouse from our Epic and IS team to make that Epic integration and all of that sort of nicely flow through into our ClickView app so we can analyze the data. And then the T1D Exchange Collaborative, thank you so much for this incredible honor for me to be in front of you guys today and share our exciting work. Thank you.
And I see Dr. Golden has a question.
Thank you. So Lauren Golden from NYU on the adult side in New York. That was great. So I have 2 questions, if I may. One is it possible to use something like this as a passport among institutions, between the different institutions, with a question at the end that the adults would actually have to check off that the patient arrived. Because we've been doing it manually. Obviously, not all of our institutions are on Epic, but for example, at least for those who are, I'm actually just wondering, do we need to recreate this, or could you guys just have that final question and we could say, yes, they're here. So that's one question. We also have been struggling with folks with public, like some of the Medicaid plans, that pediatrics takes a lot of plans. The adults are told we can't take the same plans. And I don't think this is unique to us, but I'm wondering, can we leverage, is there some kind of economic conversation that we can start to have with our individual institutions about why we have to do this? I've not found, because it's the right thing to do, to be resonating in any particular way. And I think I at least need help at our site to leverage the economic reasons why we need to do this. That seems to be the only thing they're going to be listening to. So those are two, some of that may be for the group, but I'm just wondering with a passport like this specifically, could we hand it off?
Thank you, Dr. Lauren. So if I understand correctly, the first part of the question was, can we have the same thing replicated on the adult endo side into the Epic EMR, where once the patient does arrive from the PD end, then there's a checkbox that, okay, the patient has safely transitioned. Oh my gosh, that would be amazing. And that would make our data collection so much easier and just feasible and seamless. And then the second piece was, remind me again, sorry, the second piece. Yes, definitely. I think there's so many ways that we can do that. We can look at, I think that answer can probably be best given by Dr. Nana here. But some of the DKA rates, right? So we've seen what Dr. Carruthers has shown us, that when there is that large gap in care and the hospitalization rates, the A1C rates, the DKA rates sort of all, are going very negatively affected. So if we can showcase that data to the higher up powers to be, perhaps we can convince them. I think one of the biggest struggles that we have is we don't have very many accepting adult endo providers who take public health insurance. So that's been our biggest barrier. But with that adult endocrine provider list that I was mentioning that we give to all of our patients, we do try to find a adult endo who will accept Medicaid and Medicare populations.
So this, Nicole said we have to be quick. So this is for Nicole. So I think this conversation is great. So I think T1DX has almost like here a mandate to look at maybe health outcome complication rates for those that do not successfully transition compared to those who successfully transition, which would then like roll into an economic model that cost more, that cost the health system more when patients fail to transition. And then I think another mandate we have is to our EHRs to create some type of interportal so that we can seamlessly document when patients successfully transition and when they don't. Like not only when they did arrive, but when they actually did not arrive. That's for you, Nicole.
So it is a great question. I think, what we're documenting for transition is pretty bare bones right now. And so we're not asking those questions. We're not collecting that data. So, people have to be committed to being able to identify like what is the definition of success and like are we tracking it? It's kind of reminds me of like when we did depression screening, are we actually making the referral? Did the person go somewhere? Did they receive access to care? So I think we need to connect the dots. We have the capability of tracking and receiving that data, but you all have to be willing to ask the questions, track it, and share it with us. So, and this is a good just recognition of the transitions work group. If you care about these things, you can connect with the transitions work group so that you can be a part of this process of making the data available. I'm going to give this to Georgia since we're in her hometown, but we're going to have this as the last one.
Had a quick question. So, at Grady, we don't have restriction on who can come to our clinic. We care for uninsured patients as well, and we still struggle with transitioning kids from CHOA to Grady. I am just curious if anyone's collecting data on the young adults plan and what geographic plans to move might, impact this. So I feel like we see a lot of patients who go in and out of care in this time because they've moved and then they're coming back. And that definitely impacts our insurance coverage and their ability to find that if it's public. So I just wanted to make a plug for maybe some more data on that side.